And again, happy anniversary.
Oh, thank you very much. Yes, special day
Yeah,
for us.
yeah, do spill. How many years?
This will be year number 7 for us.
That's a good,
We've been
that's a good
together
number.
many, many years. We've been together over 20 years, but the last 7 has been solidified. Let's put it that way.
Well, seven's a nice number. There's special to 7.
Yeah,
Awesome. 7 adventurous, beautiful years.
they have been. Yes, and hopefully many more to come.
Good. I have confidence in that. So, well, let's get right to it. So today we're going to talk about antidepressant medication, and you shared some fantastic information to our group recently. So I'm going to let you take it away. If it's okay, I'm just going to be like, hey, if I have a thought, I'm going to like stick my hand up and try to interrupt you, because I know when I listen to the conversation that you had with the group, I did have some questions that popped up, and I think I covered some of them in our last one, but I'm sure more always pop up. So I'll just let you take it away.
Great. Okay. And one of the big reasons why I wanted to address this topic is that not very frequently, but often enough, I get questions from Parkinson's patients asking about if there is an antidepressant medication on the market that's specific for the Parkinson's population. Because unfortunately, depression is a part of Parkinson's. It's as much a part as the stiffness, the slowness, and the tremors, and it deserves to be treated the same way, aggressively, when and if it happens. So there's kind of a long and a short answer to that question. The short answer basically is no. There is no FDA-approved antidepressant specific for a Parkinson's patient. However, a little bit longer answer to that is there are many antidepressants on the market today, fortunately. And interestingly enough, almost all of them work just as well in Parkinson's as they do in the general population. So whatever ones that we have out there right now, they work very well in the Parkinson's patients. And maybe that's the reason why they haven't really done a lot of studies and try to create a whole new class of medications specifically for Parkinson's. But we have to realize that mood in general is dictated chemically in our body, specifically 3 chemicals, 3 neurotransmitters. One is serotonin, the second is norepinephrine, and the third is good old dopamine. And if you're a Parkinson's patient, you've heard the word dopamine on infinitum, because it is the key to it. That's really what Parkinson's is all about, that deprivation of dopamine. So clearly, if it plays a role in mood, you can see that depression is really an integral part of Parkinson's. Does that mean that every patient has depression? No, it does not. But I can tell you the statistics that it's pretty high, probably 40 to 50% of patients at some point in time do experience or exhibit symptoms of depression. So it's noteworthy enough that we need to address it. And the way we're going to do that is if patients on their own do any research as far as depression and Parkinson's, they're going to see that the drugs that we use are broken up into categories, and they're always referred to it in that way. And the first category that really I want to talk about, because it's the most popular and the one that pretty much has the most drugs, and that's a group called the SSRIs. And it stands for Select Serotonin Reuptake Inhibitor. There's a lot of verbiage there, but really what it's all about is that one word in there, serotonin. That as one of the 3 neurotransmitters that do play a significant role in mood. So in this group, which is probably the most popular and their household names, we'll start with the most famous, of course, is Prozac, which has been around since the early or late 80s. More popular became in the 90s, I guess. But that was really the first of this particular group, this SSRI group, to hit the market. The generic for it is fluoxetine. I doubt you see any brand name for it anymore. Shortly after that came another one called Paxil, which is paroxetine. Then Zoloft, another very common name, that's sertraline. After that came Celexa, which is citalopram, and then Lexapro, which is S-citalopram. So that's a total of about 5 SSRIs that are probably the go-to for most neurologists and or psychiatrists in treating depression, whether it be for Parkinson's or not. It's usually the go-to, and kind of for good reason. First of all, they're generally well tolerated, and we do get good results with them. They don't seem to interfere with Parkinson's medication, which of course is always a concern. We haven't come across any major drug interactions with this particular group, so that's advantageous.
Right.
Another key factor here is that they've all been around for years, decades. So we have a fabulous track record, safety track record, and safety profile of the use of these drugs. And because they've been around so long, virtually every single one I mentioned is available generically, which means they're cheap. And that's always a plus for physicians. The last thing they want to hear is that the patient left the office, went to the pharmacy, and did not get the medication because the cost was too high. So here's a situation where we've got 5 top antidepressants, all readily available at a relatively inexpensive cost, regardless of your health insurance status. So that also is a plus. Now, are they without downsides? No, not at all. One of the biggest is going to be their onset of action. They don't work very quickly. And unfortunately in our society, even today, depression and mood disorders have a certain stigma attached to them, which is a shame. And that's probably been left over from years in the past. But patients don't often address these issues because of that factor. And then what complicates it is when they do address it and they get to the doctor, only to find out that it's going to take another 4 to 6 weeks for the medication to work. And we come out of a society where we love instant gratification. We like things to happen very quickly. We're not long on patience when it comes. We're used to taking a pain medication, and within an hour, we've got relief. We take an antibiotic for 5, 6, 7 days. We're all cured and good. So to take something for many weeks, possibly 2 months, to wait and see how it affects you, that's tough. And I've seen it many times in the pharmacy where patients will start and they just never come back for the refill. They just get tired of dealing and waiting with it. But we'll talk about how that's improved over the years shortly. Some of the other downside side effects with this class is going to be GI distress. So that's kind of a collective term that we use, and that could mean one of 4 things: either nausea, vomiting, diarrhea, or constipation. So constipation, as you know, is we've talked about this numerous times. That's a huge issue for a Parkinson's patient. So that particular, if you're one of those that get that side effect, that's not going to be very favorable. However, if you're dealing with constipation and diarrhea becomes an issue for you, that may be a favorable side effect for you. But those are things to look out for. Although, again, they're generally well tolerated, it doesn't mean that every patient is going to experience that. The other thing as far as side effects with this particular group is weight gain. Now, that can and cannot be an advantageous side effect. For some PD patients that perhaps have difficulty in swallowing with dysphagia, or have they've lost their sense of smell or their sense of taste, they may not be eating properly and their caloric intake has dropped substantially, and they may have lost a good amount of weight. So perhaps that side effect for a PD patient may be advantageous. That's something the doctor will have to decide. And finally, in this particular group, there are sexual side effects because we're dealing with serotonin. So a decrease in libido in both men and women, and erectile dysfunction is also possible in a relatively large population here. We're talking about 1/3 of the population or more. Both of those can be addressed. So they're not a deal breaker at all. And I don't want to discourage patients from taking it simply because of that, because if and when it becomes an issue, it can be addressed. A lot of times just lowering the dose or adding bupropion on or something like that can very easily resolve that issue. But it does become a concern. The next group that we need to talk about, which again is used very commonly, is a group called the SNRIs. This is now serotonin norepinephrine reuptake inhibitors. So here we're dealing now with 2 out of the 3 neurotransmitters. We're dealing with both serotonin and norepinephrine. Again, there's really only 3 major drugs in this category, and they're kind of interesting. The first one, probably the most popular, is a drug called venlafaxine, often called Effexor is the brand name. The next one is duloxetine or Cymbalta. And the final one is desvenlafaxine, which is Pristique. So these are 3 drugs in this newer category. This came about after the SSRIs. Here again, they're also been used pretty successfully, but this has some advantages that the other group doesn't. So first and foremost, of the 3, the venlafaxine or Effexor is probably one of the most studied specifically in the Parkinson's population. Why that is, I'm not really sure, to be perfectly honest with you, but they just seem to pick it over and over again to do studies with. So it has been used quite favorably in the Parkinson's population. Does that mean it works for every PD patient? No, not necessarily, but it is kind of a favorite or a go-to when it comes to treating Parkinson's patients. The other advantage that you get with this group that you don't get with the SSRIs is that it seems to be very effective for pain. And pain is something, as I mention all the time, it's underspoken as far as Parkinson's. A lot of Parkinson's patients have neuroleptic pain or nerve pain, and that becomes problematic. As a matter of fact, Effexor is actually indicated for diabetic neuropathies, which again is kind of this pain or tingling, numbness that patients get in their extremities with diabetes, long-standing diabetes. And you can use venlafaxine to treat that. Also, the other drug in this group, the Dulexor or Cymbalta, that's used for fibromyalgia as well. So you can see as a class, they are used for pain outside of being effective antidepressants. So that may also be an advantageous for a physician to lean more towards this group if he's got a PD patient that's dealing with both pain and depression. So that's kind of a nice tool to have in your tool bag if you have to go that route. Here again, there is no advantage as far as onset of action with these drugs. They still take that 4 to 6, even 8 weeks sometimes to work. So I emphasize to patients, please be patient. If the doctor does put you on this, don't give up after 10 days or 2 weeks. To be fair to the medication, go to full 6 weeks and see what happens.
Does the do you know if the effectiveness for the pain takes as long as the effectiveness for the antidepressant? So
I'm sorry, I didn't hear.
So do you let me rephrase that. Do you believe, or is that the effectiveness of the medication, right? Taking 4 to 6 weeks of the SSRI, does it help quicker with the pain? Does the pain effectiveness come sooner than the depression effectiveness?
Good question.
Okay.
Yes, the answer to that is yes. You know, the mood altering component of those drugs is what's taking so much time to build up that excess serotonin or norepinephrine that we need to actually affect mood, whereby the pain component is being handled in a different chemical aspect. So yes, how quickly, that's going to vary depending upon the severity of the pain, where the pain is and whatnot. But I would not expect a 6-week wait time to see that. Although it's interesting because it would probably progress, the benefit would probably progress with the longer you're on it as far as its pain component, but the patient would see results quicker for pain relief than they would for depression relief.
Right. And I'm assuming the pain relief isn't just like if I cut myself and I take a Tylenol to like help that one spot, it's got a different, probably a whole different.
Totally different pain. That's a complete different pain. You wouldn't be able to pop this pill, like you said, if you cut yourself or you fell and you broke your leg, they're not going to put you on venlafaxine for that. That's a totally different type of pain. This is what they call neuroleptic pain, or pain that what we refer to it sometimes as nerve pain. And it can be very debilitating. It can be a burning sensation, or that pins and needles sensation that you get sometimes when your hand falls asleep, but to a much powerful degree than that. So these can be a nice add-on, and the benefit here, especially in a PD patient, is we don't need to deal with opioids or narcotic medications because of that pain, which is really, that sets off a whole storm of problems for a PD patient when you get involved with narcotics. So we really want to try to avoid that. So this is a super nice option for physicians to go to. So again, the time frame for the depression is about the same, about 4 to 6 weeks for most patients. The only thing interesting with this particular group is it increases blood pressure, where you don't seem to get that problem with the SSRIs. And the reason why it happens here is because this group deals with elevations in norepinephrine. And that happens to be a very powerful vasoconstrictor. So we do need to monitor blood pressure when you're put on one of these 3 medications because of their influence on norepinephrine. Now, here again, in a PD patient, that may not always be a bad thing. As we've spoken numerous times, Parkinson's, low blood pressure is very common in Parkinson's. Some patients really battle it substantially, and they get lightheaded and dizzy, and orthostatic hypotension is a problem. So giving a drug that might kick that blood pressure up a few notches may not necessarily be a disadvantage to a PD patient. The general population patient, that could be a problem. But nonetheless, either way, it will be monitored. You'll either be asked to monitor it at home, or the physician will have you monitor it closely when you come in. So that's definitely something that we have to be concerned about. The sexual dysfunction is going to be the same as it was for the SSRIs. And honestly, if I had to pick one of the 3, and that's a bigger culprit in this particular group, it's going to be the venlafaxine. Why? I can't honestly answer that. It acts the same way on the same chemicals as the other 2, but it seems to be reported more often with venlafaxine. That may just simply be because venlafaxine's more prescribed than the other 2, so that's a possibility as well. But nonetheless, it still exists with this group. The next group that we really want to talk about, which is going to be kind of the final group as far as the ones that we use most often in depression, and that's going to be the atypical. Obviously, the name implies that it's atypical because it doesn't fit into the other categories that we have. And there are other ones that are out there. I don't want them to think that there are only 3. There are other ones. There's the tricyclics, there's the MAOIs, but they're just not relevant for Parkinson's. Highly unlikely you would see that group prescribed for Parkinson's patients. So that's why I'm limiting it to these 3: SSRIs, the SNRIs, and these atypicals. In this class of atypicals, there's going to be 3 we'll mention. The first and foremost is going to be one called bupropion. This is another very, very popular, widely prescribed drug. And it's had a couple of different uses, from antidepressant to, we used to, under its brand name Zyban, we used it to help stop smoking. It seems to have a very powerful effect on cravings. So they started using that as an anti-smoking deterrent. I don't see it used much like that anymore, but it was. Its brand name is Wellbutrin, and it's been around a number of years. The nice part about using this is, since it works on norepinephrine and it works on dopamine, so 2 neurotransmitters that we haven't seen in combination. We've seen serotonin by itself, we've seen norepinephrine and serotonin, but we've never seen norepinephrine and dopamine being modulated by a drug until bupropion came around. So right away, we're going to see, here again, we're dealing with norepinephrine, so elevation in blood pressure is a possibility. But the nice part about this, because it has no effect on serotonin, it has no sexual side effects at all that we can recognize. So that's advantageous. It can even be added to a drug. Let's say someone's on Zoloft and experiencing some issues or side effects. very often the doctor can just simply add the bupropion, add onto that regimen, because it doesn't affect serotonin, where Zoloft does. So now you'll have the Zoloft handling serotonin and the bupropion taking care of norepinephrine and dopamine. So you're getting all three neurotransmitters being modulated by these two drugs. And that can be an effective way of eliminating some of those side effects that you see with the SSRIs. The other thing too with bupropion is a decrease in appetite. Again, like I said, they use this for cravings, which is why it became popular to stop smoking. But I would imagine desire to eat and food and whatever is part of craving as well. So not that it's ever used that I know of as a weight reduction agent, but it can reduce the appetite. So that might be a problem for some PD patients that are already thin and frail to begin with. So that would have to be monitored. Weight would be monitored very, very closely with this. The other nice advantage with this is it's been around a long time. It is very inexpensive. So here again, it's available to everybody at a relatively inexpensive cost. And because of that, a lot of doctors like that because of the fact that if they start a patient on, let's say, bupropion, and later in therapy, they're not seeing the results or the patient's not happy with that, they can always add one of those SSRIs, the Prozac, Zoloft, Celexa, or whatnot, without having to worry about added side effects, because that group only deals with serotonin and this group doesn't have any effect on that. So that's why they like using that, because it's great to add on other drugs. The second drug in this group is one that I don't really see used that much anymore. At least I never did. We used to just kind of dust the bottle off on the shelf. It was not very popular. It's a drug called metazapine, or Remeron is its brand name. Now, again, this affects serotonin and it affects norepinephrine. It does not have a role in dopamine like bupropion does. So its mechanism of action is a little bit differently. But one of the reasons I think that it lost favorability is because it's very sedating. And patients did not like that, especially if they need to be functional during the day. There was a lot of grogginess and tired fatigue associated with it. So that was one disadvantage. But one advantage to this is it seemed to increase patients' appetite. So here again, this could be an advantageous choice for a PD patient. First of all, insomnia is very popular in Parkinson's. So it's conceivable the doctor may be presented with a patient that has trouble sleeping, is also thin and frail, has lost weight because of, like I say, other issues, swallowing issues, smell and taste issues. So here, Remeron may be a good choice because it is very sedating. So we could dose it, perhaps tell the patient, take it at bedtime. And with that added advantage that it stimulates appetite, we may be able to elevate that caloric intake somewhat for that patient. So that combination for a PD patient could be very advantageous. The other of noteworthiness on this one is dry mouth. That's often a chief complaint that people have, and that can be very annoying, especially in a Parkinson's patient who has trouble swallowing to begin with. Dry mouth is really irritating, although it's usually an easy fix with some kind of hard candy or lemon drop or something like that. And finally, the third drug in this group is a drug called trazodone. Its brand name is Desril. This is very popular, but it's popular for the wrong reason. It is an antidepressant. It's officially listed as that. It's indicated by the FDA for depression, but you seldom, if ever, see it used that way because, again, of its sedation properties. People fall asleep with this at even the lowest of doses. So what's happened over the years is that it didn't really do a great job as an antidepressant, but doctors were noticing it worked great for treating insomnia. So rather than give a patient like an Ambien, which is Zolpidem, or some barbiturate or narcotic to help them sleep, They were able to use the trazodone as a sleep agent. It's not a narcotic. There's no habituation associated with that. And it works very effectively, and it can work along with the other antidepressants that the patient may be on, or even anti-anxiety agents. So it became, and still is, a very favorable choice to help patients sleep. The problem with using it as an antidepressant is dose related. They found over the years that in order for it to work as an antidepressant, you need about 400 milligrams of this. So you can see the comparison here. If we're using only 50 milligrams to put you to sleep, but we need 400 to treat you as for depression, you're just not even going to be probably conscious at that level, 400 versus 50. So, and you can go even higher as an inpatient. I believe the dose goes as high as 600 milligrams if you're an inpatient. So again, and they can use it. It is a viable option for some patients that have very, very deep depression. I would imagine it's still used in those high doses for patients for a select group. But in the real world, we see mostly in the retail setting, out of the hospital, a low dose 50 milligrams is really what's the most popular. Now, essentially, those are the three major groups that we have for treating depression. Oftentimes, depression is coupled with anxiety, and the two go hand in hand. Not to belabor the point, but very often we can use these antidepressants. They work quite nicely as an anti-anxiety agent for patients who are suffering from that. So you can get the best of both worlds, for instance, with using an SSRI like a Zoloft or a Celexa or a Paxil, Lexapro, where you can get anti-anxiety relief and you can also get the benefit of antidepressant relief.
Right.
Most of the time, a lot of times, the most popular drug out there for anxiety are going to be benzos or benzodiazepines. And there's really four that's still in use that's very popular. Of course, good old-fashioned Valium. It's been around forever. Again, another household name drug, which is diazepam. Then came the onslaught of the rest of them. Then you had Ativan, which is lorazepam. You had Klonopin, which is clonazepam. And then you have Xanax, which is alprazolam. So those four are the biggies. The problem here is that they're not always, they do a great job for anxiety. They have a very rapid onset of action. Most of them have a short duration of action. They can be dosed more than once a day if need be. The problem is that in Parkinson's patients, they can cause a lot of confusion, a lot of lightheadedness, dizziness. They may irritate or aggravate hallucinatory states. So it's not that you can't use them, but you have to use them very judiciously and cautiously in a Parkinson's patient to prevent those symptoms, because ultimately those symptoms result in a fall, and we know how terrible that is for any patient. So it's not uncommon to see, and a great combination is we'd have that 4 to 6 week window of when we start an antidepressant. Nobody wants to wait that long. So a lot of times what doctors will do is they'll combine the two. They'll start an antidepressant and a benzo at the same time, because the benzos work quickly. So the patient sees some relief, and then while the blood level is building of the antidepressant, they're getting some relief from the anti-anxiety agent like a benzo. And then as time goes by, the doctor will wean you off of that benzo just in time for that to really reach its peak, and then you can get the benefit of the antidepressant. And then they'll tell the patients to very often say, look, you can take the benzo on an isolated, as needed basis if you're having a panic attack or you're having a bad morning, whatever, but not as a steady diet. And that's a very effective way of treating that.
Can I interrupt real quick?
Yes.
We have just a few minutes left, and I did have a question that I wanted to go back to your bupropion. Did I say it right? You say things so well. Bupropion, is that right?
Bupropion.
Okay, yes, that one. The one that seems like there's a couple in here that I like put stars next to. Like this seems like so awesome, and but I don't even know how to form my question. When so you can take off of how I'm thinking here. When you're struggling with creating dopamine and you're taking carbidopa, levodopa, that assists and then you're taking an antidepressant that actually is working directly, has a role on the dopamine. I'm just like, does it help increase the brain's own ability to create dopamine, or is it making the little dopamine that's already been created more effective? I'm just curious about that whole chemistry and what's going on with that.
Super great question. So what's really happening here is you're not really, these drugs that affect dopamine, for instance, bupropion, it doesn't manufacture more dopamine. It's a reuptake inhibitor, meaning that once dopamine gets released from the presynaptic side and it's delivered its message to the postsynaptic side, then it's just hanging around. So what happens is the body has a fabulous way. It says, look, you just because you delivered your message, you're not going to sit around and do nothing. So I'm going to take you back up again. I'm not going to let you sit in the synapse between the two of them. I'm just going to take you back up and recycle you again and make you deliver another message. You're more than capable of delivering one message. You're not just going to hang around the synapse. So that's what these drugs do. And that's why they're called a reuptake inhibitor. So it prevents that reuptake. So now it sits there and begins to accumulate in the synapse because it's not being sucked up back into the presynaptic side and made to go around again. Now we're building up an excess of serotonin. We haven't, of dopamine rather. We haven't generated more. We're just allowing less of it to get sucked back up into the presynaptic side. So now that level is beginning to build, and then it can go about, maybe the body will take it and use it someplace else or help with muscles or mood or whatever. But it's a way of elevating that and blocking that reuptake that takes place. And that's really how these drugs work. Without having to elevate, we don't generate more. I wish we could generate more dopamine with them, but they just prevent it from being pulled back into the presynaptic side.
Okay, that's awesome. It's a good thank you for that. Now, so if this say it again,
bupropion, yep.
Say it again.
Bupropion.
Okay, got that last bupropion. If that assists on the role of dopamine, if it helps, no side effects, helps the cravings, and again, that could be a caution if you're underweight. So if you're not underweight, helps with depression. I'm assuming if it's helping with cravings, it might assist with impulse control. If that's sometimes something we're struggling with, Parkinson struggles with. Does it have, and I didn't hear you say if it did have any kind of GI effect, because it almost seems like this antidepressant, above all of them, again, even especially adding with the Zoloft, seems like this beautiful little mixture of too good to be true. So tell me if there's anything negative about me, if I had Parkinson's, going to my doctor today and saying, I want to try this.
Yeah, okay. So first and foremost is the GI portion of that is, yes, there are GI side effects. However, again, like the other ones, they're minimal at best. It is a group of drugs that's extremely well tolerated, and very rarely would you ever see someone having to come off of it simply because of GI side effects. So that's of benefit for that right away. Is it for every patient though? No. I can tell you, I had a conversation with one of your patients that you had afterwards that was telling me, I was boasting about this, and they were telling me that her husband was on it and did terrible. It didn't do anything for him, and he was on it for many, many weeks. So it just drives the point home that yes, we talk about these drugs in a favorable light, but it doesn't always mean that they're suitable for every single patient. And that's why we have these options of some affecting only one inhibitor, some affecting two, some infecting or modulating three, because every patient's mood or depression and at the level that they're in depression is different. So we have many options out there, which is great for the neurologist and or psychiatrist to dig into his tool bag and come up with many options and many combination of options. One of the questions that came up was, I'm not seeing great benefits at the dose I'm currently taking. Should I suggest the doctor go to the next highest dose, which was they were currently on 150. The next dose would be 300. No, that's not always the right way to approach that, because as we go up the scale in milligrams, we're also increasing the odds of side effects. So perhaps keeping it at the 150 level and adding a lower dose SSRI or an SNRI to the regimen might be a more effective and efficient way of doing it without causing a problem side effect wise for the patient. So again, it's always on a case by case basis, but that's the beauty of having multiple choices from the doctor. And that's why I said right from the beginning, there isn't one specific one for Parkinson's, but all of these can and have been used in Parkinson's patients very successfully.
Right. And that's our goal. Our goal is to make sure with the information that you have and the opportunities that we have to present it, that people are truly educated about the options, because until you start sharing the options, you don't know that there are options. You just listen to like, hey, and so coming with the, and I guess in the last, we've got less than a minute left, so about 30 seconds, but in the last couple of seconds that we have, our goal right here, you and I, Bob, right, is like to educate, like you learn it. So you go to your doctor with tools and with your notes and you go, okay, let's talk about this and this. And so the beauty of information is of personal information. If I'm struggling with Parkinson's, to walk in there with the knowledge of this is incredible.
Absolutely. And they need to treat it. Don't disregard the depression part of it, because you'll see when you're depressed, all your other Parkinson's symptoms seem to get worse. And that just adds fuel to the fire. So don't ignore